This is Blood and Cancer, the official podcast of MD Edge Hematology Oncology. I'm the voice of MD Edge Podcasts, Nick Andrews. And I'm joined this week, as I always am, by the editor-in-chief of MD Edge Hematology Oncology, Dr. David Henry. And Dr. Henry, I'm back from California. You're back from the wedding. I think everyone is settling in, for autumn.
Well, almost settling ill. It was, yes, as we said last week, the wedding was tour de force, and it took a while to get my head back into action and taking care of patients, but we're all back at work and just having some fond memories, of course, forever about all of that.
Absolutely, and I can't say that I don't miss sunny Southern California. I do a little, but alas, we're here together now. So coming up later, you've got an interview that you did with Dr. Cohen, who is also at the University of Pennsylvania. You discussed a recent melanoma case and a conversation about when to use different things.
Yeah, this was really a fun interview. Dr. Justine Cohen is a new faculty, and as she was looking over the place in her office, I said, listen, let's take advantage of your expertise right here and now. And so she's expert in melanoma, actually in lung cancer and immuno-oncology therapies. So we focused on melanoma and whether to use a targeted therapy, the BRAF mutation business, or a checkpoint inhibitor, and when to do it, what are the results, what are the side effects. Really nice interview.
So that's coming up later. The interview again, Dr. Justine Cohen. You can find a link to her biographical information, as you always can, in the show notes. And following the interview, we always do, have a conversation with Dr. Ilana Yurkiewicz. It's clinical correlation. It's back after 3 parts of her fellow conversation, and this is a really interesting one. It's about how a patient's anxiety about risk or prognosis, and in her instance, it's about risk, can impact how a clinician makes decisions, and specifically, do maybe you downplay risk or accidentally possibly make a patient more anxious in navigating those waters?
Well, this is not rare. You'll be talking about a particular diagnosis and therapy, and as you're going through the therapy and its possible side effects, and you either mention, I'm thinking, for example, of adriamycin AML, acute leukemia, really rare. But if you go click through the possible side effects, the patient goes, oh, I've heard about that, or they'll ask about that, and they hear almost nothing else. It's hard to get off that conversation. It's really rare. It couldn't have, I've heard my neighbor said his uncle had it, and so I'm really worried about it. So it's difficult to focus that conversation back on track to what's really likely and what's really important sometimes.
Yeah, absolutely. And of course, if you missed any of the 3-part conversation with Dr. Yurkiewicz and the 2 students who write the show notes, or I guess they're trainees who write the show notes,
right.
Residents, yes, Dr. Emily Breyer and Dr. Ronak Mystery. The 3-part series are available in the most recent episodes of Blood and Cancer, and you can find links to those as well in the podcast notes. Okay, it's time for This Week in Hematology and Oncology. We have an FDA approval, a new approval for an old drug. The FDA approves rivaroxaban for VTE prevention in hospitalized acutely ill patients. So another tool in the toolbox to make sure those patients who are inpatients and acutely ill can avoid a huge risk.
Well, things in our area move so quickly. As you said, an old drug, well, it was 5-7 years ago when these were called the NOACs, novel oral anticoagulant agents, antithrombin coagulants. And then that became no longer novel, so they became the DOACs, the direct oral acting. And they have a wonderful experience, outpatient treatment, prevention. And now, as you say, every week you tell me something new, that this is now approved for acutely ill hospitalized patients, where we typically use subcutaneous heparin for VTE prevention. Now we have this drug, which one size tends to fit all and works instantly.
Sure. So let's take a look at the trials that led to this approval. It comes from 2 phase 3 trials, the MAGELLAN and the MARINER trials, which included more than 20,000 hospitalized acutely ill patients. Rivaroxaban demonstrated non-inferiority to enoxaparin. Am I saying that right?
Correct.
Enoxaparin, a low molecular weight heparin, and in short-term usage, it was superior over the long term compared with short-term enoxaparin. I'm going to get better at this Latin thing, I swear. I don't have to go to medical school for it. While VTE and VTE-related deaths were not reduced in MARINER compared with placebo, patients who received rivaroxaban did see a significant reduction in symptomatic VTE with a favorable safety profile. And as you mentioned, it's been the drug's been out there for a while, so everyone knows the safety profile. And I like I said, I think anytime you can find new uses for drugs that are out and about, I think that's probably a pretty good thing.
Yeah, I think this is really a good development of taking drugs that have been out for a little bit of time, and as they slowly get different approvals, better approvals, replacing maybe some old therapies, it's a nice progress.
You can read more about the trials that led to the FDA approval of rivaroxaban for VTE in acutely ill patients by clicking the link in the podcast notes, and you can stay up to date on all your latest news for hematology and oncology by visiting mdedge.com/hematology-oncology. Dr. Henry, it's time to kick it over to your conversation with Dr. Cohen.
Look forward to hearing it. It's a really nice interview. Here we go. I'm Dr. David Henry, your host and editor-in-chief of the online journal mdedge.com/hematology-oncology, and you're listening to our podcast today, Blood and Cancer. And I'm delighted to be interviewing today a new acquisition here at Penn, Dr. Justine Cohen, who is a new clinical assistant professor of medicine with an expertise, of course, in oncology, and in particular melanoma, lung cancer, and lots of immunotherapy issues, side effects, application. Justine, welcome to this podcast.
Thank you so much for having me.
Well, it's a pleasure. And again, we're delighted to have you here at Penn and starting as a new oncologist. So I wanted to take advantage today on the podcast with your expertise in melanoma. And I thought, as you suggested, we would talk about first adjuvant setting. So why don't you describe your first case, adjuvant setting melanoma?
Okay, so I have a case of a 42-year-old female who presented to her dermatologist with a lesion on the back of her leg. The lesion was darkly pigmented, and over time it started to itch and bleed. Shave biopsy showed a 2.30 millimeter superficial spreading melanoma, which was ulcerated and had two mitotic figures. The margins were positive, and she underwent a wide excision, which showed scar with no residual melanoma, and a sentinel lymph node biopsy of the left inguinal region, which showed one positive lymph node. That one positive lymph node had a focus of 2 millimeters and no extracapsular extension. She did have a full molecular profiling, which every patient should do at this point in our decision making, and it did not show a BRAF mutation, so it was BRAF wild type. However, there were several other UV signature mutations indicating that this was a melanoma that had come likely from sun exposure. She had staging scans with a PET CT and an MRI brain, which were negative for metastatic disease. So her final stage was a T3B N1A M0, according to the AJCC 8th edition, which is the edition that we're using now, and that would characterize her as a stage 3B melanoma.
So BRAF not mutated, would you say the breakdown is 60-40, 50-50? How many are and are not at the outset BRAF mutated?
It's about 50-50. I would say 50% of patients have a BRAF mutation.
Okay, so she did not. So let's go on to, you've biopsied her, staged her, lymph node is positive. What's your treatment for this patient?
So, the past decade has just been this remarkable time of advancement in the field of adjuvant therapy for patients with resected melanoma. And we have so many options now that it sometimes can become confusing when making a treatment decision. And there's even a lot of debate within the melanoma community about which treatments are the right treatments to give. And sometimes there's no right answer. So we'll talk about a couple of them and the data behind them and how we make this decision. So there have been several new approvals, including immune checkpoint inhibitors and targeted therapies, which are BRAF and MEK inhibitor combinations. And BRAF inhibitor combinations are being used for BRAF mutated patients. Those patients have V600E or V600K mutations. Immunotherapy can be used for patients that harbor a BRAF mutation or that are BRAF wild type. And just a little background on how we got to where we are today. Before we had immune checkpoint inhibitors or BRAF inhibitor therapy, we only had high-dose interferon. And high-dose interferon has had really mixed results when we've done all of these meta-analyses, but basically showing really, really modest benefits in overall survival and disease-free survival. And a significant amount of patients, at least 78% of patients, experience grade 3 or higher toxicities. Essentially this is a super intensive regimen, and patients feel like they have the flu for an entire year. So we really have fallen out of favor for using high-dose interferon with much newer therapies that have come into the clinic.
I'm so glad I've been around long enough to have used it, and it really is uncomfortable and really full of side effects for the patient. So I'm glad we moved on.
We have. And so the next therapy that became approved that we really started using in the clinic was high-dose ipilimumab. So ipilimumab was approved at 10 milligrams per kilogram based on the EORTC 18071 trial, which was a phase 3 randomized double-blind adjuvant trial of ipi 10 mg per kg versus placebo in patients who had had fully resected stage 3 melanoma. And the trial revealed a risk-free survival, a recurrence-free survival benefit in patients who received ipilimumab. And at a median follow-up of 2.74 years, the median RFS was 26.1 months in the ipi arm versus 17.1 months in the placebo group. The hazard ratio was 0.75. And this trial took place many years ago. And so actually at the 5-year follow-up, there was a consistent RFS benefit, 40.8% in the ipi group compared to 30.3% in the placebo group. And the overall survival of patients who received ipi was 65.4% versus 54.4% in the placebo group. So there really is a survival benefit in patients who were treated with high-dose ipi. However, it comes at a significant toxicity cost. There's a high rate of grade 3 or 4 adverse events. At least 41.6% of patients had a grade 3 or grade 4 immune-related side effect. There were 5 deaths on that trial due to immune-related side effects. And at the time when that was the only treatment that we had available, it was a real discussion with patients because of the extreme side effects that occurred. Now, there have been some trials looking at lower doses of ipilimumab to see if they were just as effective, but really the only approval for ipi for the adjuvant setting is at 10 milligrams per kilogram. Now, more recently, we've had approvals of the anti-PD-1 immune checkpoint inhibitors, nivolumab and pembrolizumab in the adjuvant setting. So since they've been approved, we do not use ipilimumab anymore, which is a huge relief for patients and doctors.
I can imagine, yeah.
Adjuvant Nivo was approved based on the Checkmate 238 study, which compared ipi 10 mg per kg, which was the dose we just talked about, versus nivolumab. And the nivolumab was a standard dosing that we use today. The 12-month rate of recurrence-free survival was 70.5% in the Nivo group versus 60.8% in the ipi group. And as we would have expected, there was a much lower rate of toxicity in the patients who were receiving Nivo versus ipi. So Nivo was approved based on that. And then even more recently in the adjuvant setting, pembrolizumab was approved, and that was based on the EORTC 1325 or Keynote 054 study, which was a double-blind trial of pembro versus placebo in resected stage 3 melanoma. And at the median follow-up of 15 months, pembro was associated with a prolonged RFS compared with patients who received placebo. So the 1-year rate of RFS was 75.4% in patients who received pembro versus 61% in patients who received placebo. And basically what we saw between those two studies in terms of side effects was what we see in the metastatic setting. So patients who receive anti-PD-1 therapy have a toxicity rate of about 14 to 15%. So 14 to 15% of patients develop a significant toxicity, and that's exactly what we see in the adjuvant setting. This is much, much more manageable than high-dose ipilimumab.
So much more tolerable, more interesting in terms of the immune approach and mechanism. So if there are two good, you've said pembro and nivo, so we don't keep stumbling over these words. If there are two good immune checkpoint inhibitors for adjuvant treatment, how do you pick which one to use?
So there's really no right answer. They're both fantastic options for patients. Nivo was recently approved. So it was approved at 240 milligrams every 2 weeks initially, and then it actually was approved. Another approval was for 480 milligrams every 4 weeks, so double the dose every 4 weeks. So you have the option to give patients every 2-week dosing or every 4-week dosing for the Nivo. There are slightly higher rates of initial infusion reactions with the Nivo 480, but according to the studies and according to the company, there is not a difference in toxicity between the two in terms of immune-related side effects.
Okay.
Pembrolizumab is given every 3 weeks. There is some talk about moving it to every 6-week dosing, and I think that that's probably in the future. It really depends on the patient. If you can trust a patient to report side effects to you, and that patient is coming from far away, well, maybe every 4-week dosing does make sense. I think every 6-week dosing 6 weeks is a long time to go without seeing your patients that are getting active therapy. If you have a patient that you're worried about them reporting side effects, then keep them on the every 2-week dosing. I tend to do the every 2-week dosing for Nivo or the every 3-week dosing for Pembro. I like to see my patients more often, and as we all know, the key to successful administration with immunotherapy and minimizing toxicity is good communication. So having them come in and report side effects is much more effective than relying on them to call when they have diarrhea.
Yeah, and I use, not in melanoma, but many of the other more common tumors like lung cancer use this immune checkpoint inhibitors, and I've heard you speak about this. The ones I specifically look for are the pneumonitis. I tell them any itis, so the lung, the colon, the rash, liver function, and then, of course, many others, which I think we're going to cover on another podcast. But what if this patient has an immune-related adverse event? Do you resume to finish the year of adjuvant therapy, which you're trying to do, or switch therapies?
It's a great question. I often get that question from patients and other oncologists. And, I think a lot of it depends on, first of all, how aggressive their melanoma was and how much of the therapy they received before they started getting a toxicity. So, for example, if this patient received 6 months of Nivo every 2 weeks and then developed a grade 3 diarrhea and had to stop, I wouldn't resume therapy and I wouldn't switch her to anything else. I would say she got 6 months of therapy. There is nothing magical about 360 days of therapy. That is just what the clinical trials that's the way they were designed. But I do think as we move into the future, we do need more trials to determine what the optimal length of therapy is. And we may find that a shorter length of therapy in the adjuvant setting is just as good as a year. And so I tend not to push it in terms of patients that are getting side effects in the adjuvant setting. This is to reduce their risk of a recurrence. They do not necessarily absolutely need this.
So, all right, this particular patient, she's BRAF wild type, but some people aren't. Tell me about the targeted therapy options with or without the BRAF mutation.
So the targeted therapy option that we use is the combination of dabrafenib and trametinib. It's the same doses that we use in the metastatic setting, and the data for it came out of the COMBI-AD study, so the combination of dabrafenib and trametinib in the adjuvant study. Just a little background: before combination immunotherapy, combination targeted therapy even existed, there was a clinical trial of vemurafenib, which is the oldest BRAF inhibitor in the adjuvant setting, and the study didn't show great outcomes, but we learned a very important lesson from it. That there was no disease-free survival benefit in patients with 3C, and it suggested that maybe patients who are more likely to benefit from adjuvant targeted therapy are those with a lower disease burden. So the 3Bs might have a better, 3As, that's another conversation, but that patients with 3C and probably now in the new staging system 3D, maybe those are the patients that don't benefit as much from BRAF targeted therapy. However, we do use it in a wide range of patients. I mean, especially patients with who cannot receive immunotherapies. They have underlying autoimmune diseases. That would be a classic candidate. It's a discussion with the patient, but the results of the COMBI-AD trial showed that 3 and 4 year recurrence-free survival was about 59%. And in the patients who received the combination of dabrafenib and trametinib, about 40% at the 4-year survival mark.
Okay, so again, thinking toxicity, all of us listening have used these and seen the toxicity, hopefully not too often. I've seen some bad pneumonitis, but fever seems to be a real issue, one of the hardest to manage. Do you ever just give up, stop therapy? Would you switch to a different immunotherapy at that point of getting fever?
Yeah, I think that the most common side effects are this really bad fever and then rashes. There's some ocular toxicity. There's a lot of erythema nodosum. But see, everything resolves when you stop the therapy, and that's a really important take-home lesson. When you stop targeted therapy, everything goes back to normal. Now, it may take a couple days for the fevers to resolve, but I think that, if somebody really has terrible fevers, I'm much more likely to try to dose reduce them, dose interrupt them. You can dose reduce as much as you need to until they stop having fevers. You can interrupt the dose, so you can put them on a intermittent schedule, a week on, 4 days off. Patients will come in, they'll say, I took 3 weeks of therapy and then I had a fever, and the fever took 4 days to go away. Well, then there you go. Then it's 3 weeks on, 4 days off. And I would much rather try to find something to get them through therapy. You could also start them on a little bit of prednisone. So 5 milligrams or 10 milligrams of prednisone is really good for suppressing the fevers as well. So I don't typically stop therapy unless I absolutely have to.
You hear a question commonly in the community that prednisone, I think of as the antidote. Patients will say, well, I don't want to be on prednisone too long because that'll negate the effect of my immunotherapy. Should they worry about that?
So for immunotherapy, that is a real issue. For targeted therapies, when we're talking about BRAF inhibitors and MEK inhibitors, there's no immune modulation going on, and so giving them prednisone is totally okay. When they're on immunotherapy, we do really watch. We tried really hard to limit the amount of steroids that they receive.
All right, so I think our audience is probably waiting to hear what you did. So we had this patient with the melanoma removed, a positive lymph node, small 2 millimeter focus. How did you treat this patient in this adjuvant setting?
So this patient did not have a BRAF mutation, and we treated her with pembrolizumab every 3 weeks for the duration of a year. During that time, we did scans every 3 months, which is what they did in the studies. And then after that, according to the NCCN guidelines, you can do scans every 3 to 6 months. And you just follow the NCCN guidelines for surveillance. MRI brains can be done once a year. Let's just say she did have a BRAF mutation. She's 42 years old. It's really a long discussion with the patient about what the options are. And what the data is, there's no data that compares adjuvant immunotherapy to adjuvant targeted therapy. So you can spin this both ways. You can argue for immunotherapy. You can argue for targeted therapy. I think some of the take-home lessons are that, targeted therapy, when you stop the therapy, all of those side effects of the fevers and the rashes, they resolve very quickly. The side effects are not long-lasting. Whereas immunotherapy, when you give immunotherapy in the adjuvant setting, you could have any itis, like you said, and they can be long-lasting. In fact, they can last forever. So in a young guy who's getting nivolumab, who has hormonal deficiencies and requires testosterone for the rest of his life, that can really affect his life. And for women, especially of childbearing age, we really don't know the effects of fertility for immunotherapy or targeted therapy. And so it is really important to have these discussions with patients, not only from a recurrence-free survival and all of the data benefit, but also for a practical standpoint of what's going to work better for this patient, what's going to work better for their lifestyle and their goals.
Very interesting. So as we draw down to a close, just 2 questions I have. One is, are you going to PET scan this patient once a month? Obviously not. And what scans might you do and how often?
So in melanoma, we always do a PET scan when we start therapy. We do a staging PET scan and an MRI brain. The MRI brain can be done once yearly after that in someone who's had resected disease and has no clinical symptoms that are concerning. The PET scans have become increasingly hard to cover from an insurance standpoint. And that's a lot of radiation to expose a patient to. In melanoma, a CT scan is really just as good, and there's no reason to do a PET CT in somebody who's getting surveillance for their melanoma. I can think of very rare situations in which a PET scan would be useful, but for the most part, we just use CT scans.
Well, let's close with an interesting question and comment. Dan Haller was on our podcast a few months ago following GI ASCO and had some interesting observations. Stage 2 colon. Who do we treat? We usually don't, but some patients we do. And he said, there's this thing called cell-free DNA. I've seen talks on this, and they can measure a molecule of this abnormal DNA if the tumor is shedding. Is that something that's coming in the adjuvant therapy field for melanoma?
Yeah, I think that is going to be sort of the wave of the future in metastatic and adjuvant melanoma and in all cancers, because this is an incredible way for us to determine if there's minimal residual disease in the adjuvant setting. And so maybe we check cell-free DNA in the beginning of treatment and we monitor it during treatment, and if it goes away, then we know we've treated the melanoma, and we can use that as a monitoring moving forward and knowing when to stop therapy. So it's going to be an important tool that we will have in the next year to 3 years that I think will change the way we treat patients in the adjuvant setting, certainly, and in the metastatic setting as well.
Well, I really enjoyed talking with you, and I think so much so that we need to invite you back for the metastatic setting and a little bit more about the side effects that occur, and you're so expert at watching for, testing for, and treating. So I'm going to thank Dr. Justine Cohen for joining us today. It's been a pleasure talking with you. And we again welcome you here to Penn, where Dr. Cohen is a new clinical assistant professor of medicine with expertise in melanoma, lung cancers, and immune modulators. You've been listening to Blood and Cancer Podcast. I'm Dr. David Henry. You can find us online where you can read show notes about our talk today with Dr. Cohen, put out by our residents. You can find us on our website at mdedge.com/hematology-oncology. Thanks so much for listening.
And that concludes the interview portion of our show this week. For more information on the topics you just heard, you can find links to references as well as an outline of the topics in the show notes. We'll be right back with Clinical Correlation. Welcome back to episode 40 of Blood and Cancer. I am Nick Andrews. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. It is normal, and it is okay to feel anxiety about a medical diagnosis. But there are also situations where that can actually get in the way of what's in someone's best interest. I recently met a patient who had a particular bone marrow syndrome that put him at a small but significant risk of developing leukemia later. His bone marrow wasn't causing him any problems right now. The anxiety about the possibility of developing leukemia was. I learned he quit his job so that he could better focus on what he called, quote, facing reality. He spent a lot of time on the internet looking up cases of other patients in similar situations. He was unable to focus on his day-to-day life. That's how overbearing his anxiety had become. He thought this was a good thing. It prepared him, after all, so that he would feel more ready if and when that day came. It was tough to try to get under this reasoning and to help him see that he could enjoy his everyday life now and that worrying excessively wasn't going to change what would happen in the future. Some people are amazingly well equipped to deal with uncertainty. They live their day-to-day lives, and they prepare for the worst without letting it really affect them. This is impressive and really hard to do. I admire it. On the other end of the spectrum are individuals like my patient who can become so afraid of the worst-case scenario they're unable to enjoy the time they have now. I don't judge what he was going through. It's really tough to carry the idea in your head that you are at higher risk than other people of developing a serious illness. At the same time, I didn't want to let his anxiety affect my decision-making. There was a real risk here. When patients like him become that anxious, I can feel it starting to make me more cavalier about the facts. Any abnormal number in his labs, for instance, could provoke me to rush to reassurance, because talking about doing additional testing would be too terrifying for the patient to hear. Why? What are you afraid of? What should I be afraid of? Doing your job well, doing due diligence without adding to the anxiety of an already very anxious person is a tough thing to do. You are responsible for a person's health, yes, both physical and mental, but ultimately you are responsible for making the right calls, even if that may add to a person's anxiety. It was good to actively remind myself of this, as one of his labs did come back abnormal. I did exactly what I would do for any other person, and not hold back because of the reaction I feared. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
Thank you, as always, Dr. Yurkiewicz, for the human side of hematology oncology care. That's a wrap on episode 40 of Blood and Cancer. Let's give credit where credit is due. Blood and Cancer is hosted by MDH Hematology Oncology Editor-in-Chief, Dr. David Henry. Our guest this week was Dr. Justine Cohen. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. Blood and Cancer audio producer is Mary Ellen Schneider. All MD Edge podcasts are produced by executive editors Denise Fulton and Kathy Skarbeck, multimedia editor Terry Rudd, and our social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD Edge podcasts, Nick Andrews. Thanks for listening to Blood and Cancer by MD Edge.